and it's my pleasure now to invite Professor Stankov to show our experience, almost 10 years experience with chimney-assisted stent grafting of the aorta.
I still remember, Ivo, the last BEC, I was up front and you did that complex arch case.
The patient is doing very well.
That was still doing well. Unbelievable. That was unbelievable.
Okay, thank you. Professor Stankov,
yes,
the floor is yours.
I'm talking about the other strategy for the uterine pararenal aneurysm. This year is 10 years after the first implantation in Bulgaria, CHEVAR. There we don't have CE mark for the endurance use for the CHEVAR, and now we have CE mark for the using the B graft for the chimney technique. It's off-label case. 1 year later, both of these devices use the CE mark for this technique of endovascular treatment of uterine abdominal aortic aneurysm. Before here, we talking about what is better, open or endovascular strategy for the abdominal aortic aneurysm. Now everything is clear. The endovascular treatment of abdominal aortic aneurysm from the any solution for the patient with abdominal aortic aneurysm, it's a standard procedure for the vascular surgery, for endovascular specialist. This is the criteria for the necessary to the implant the endovascular implant stent graft of the abdominal aortic aneurysm. It's necessary to have proximal neck minimum of 15 millimeters. Diameter of the aorta must be 28 millimeter, not more. And this is perfect patient, but we see in our practice, not all patients coming in the perfect time with the perfect parameters for the intervention. And for that, we have some option for this patient. He not have perfect parameters for the AAA. For that, we can use chimney or Schnorchel technique. We see the other solution from the Professor Nikolov. In situ fenestration, we present tomorrow one case with in situ fenestration, live case on the aortic arch. We use 1 year for the aortic arch in situ fenestration, a custom fenestration. This is some comparate one meta-analysis, the result, the primary and secondary result with two different techniques, CHEVAR and FEVAR. We don't see too much difference with primary and secondary result in these two techniques. It's a choice of the team. Some team prefer fenestrate stent, some team CHEVAR. But what is important to say here for the CHEVAR technique? CHEVAR technique can take in immigrant situation in the patient with rupture of the aortic aneurysm, because when you have everything what you need to the preferred procedure, I think you have all sizing of the stent graft, you have all size of the B graft for the chimney. You can take procedure and take the patient from the CT department and going to the angio department for the start the procedure. Not necessary to wait for anything. And we try to do this and to have all time every materials in our cut lab for the preferred chimney in the patient, indicate for the chimney with rupture of aortic aneurysm. This is the different in the peri-procedure time. We see the chimney is much faster, less fluoroscopy time for the chimney. Contrast it's low. The technical success rate, it's with different. The result in the result, we see the different in the result. It's not any significant difference in the two technique. This is the one other meta-analysis of the two different technique for the CHEVAR and for the fenestrated stent graft. We see here the renal artery on the technique of CHEVAR. It's more, we have more advanced event. This is the publication of our first chimney in the Bulgaria. And this is our experience for the aortic endovascular program. This is the 10 years statistic. We have 82 patients, 18 patients of all ever procedure is with chimney technique. With 4 chimneys, I think for the chimney for the celiac trunk, for the mesenteric artery, and both renal artery, we have 9 patients. 22 patients with 3 chimney, mesenteric artery, both renal artery. Only on the both renal artery we have 43 patients, and 8 patients we have with only 1 chimney. Total number of the chimney implantation in extrarenal aneurysm is 196. This is the primary result on the patency of the chimneys. On the first month, we have 97% patency, and on the 3 months we have reduced of the with 4% of the open chimneys, but successful endovascular, we recanalizate half of the occluded renal chimneys, and the 2 years patency of the chimneys, it's 96%. In one patient with type 1 endoleaks, successful endovascular treated with 1 more stent graft implantation of renal chimneys. This is the only one patient with 2 years type 1A endoleak. I show you one clinical case with the chimney, patient with arterial hypertension, coronary artery disease, date for extrarenal aortic aneurysm, presenting in hospital with abdominal and low back pain. This is the CT. We see the extrarenal aneurysm with out of landing zone in the normal position, and for that when you see the zone for the implantation of the stent graft is about the celiac trunk. We planning for this patient implanted 4 chimneys and going up to the truncus with stent graft. For this procedure, we need 4 access for the chimneys. We use both brachial artery and both subclavian artery, total endovascular with local anesthesia and sedation. We see the cannulation. This is the procedure, the most important part of the procedure, to the placement of the old stent grafts in the side branch, and precise everything to be on the one line for the prevent the occlusion of the some of the side branch. This is the implantation. Very important thing when you use the chimney technique, it's the first open the stent graft, balloon expandable, and after that, with the inflated balloon of the stent graft, we start the opening the self-expandable stent graft or main body, stent graft for the aorta, for the accumulate the place in the landing zone and cover the all free place for the no. Can you back 3 slide for the kissing? And още един. Може да ги пуснем като клипче. This is the kissing dilatation. Again, we first inflate the big graft. After that, we inflate the balloon of the main body, and the inflation is going first. They inflate the balloon in the main body, and after that, we de-inflate the balloon of the big graft. This is the final result. We see patency of the all visceral and renal artery, and isolate abdominal aortic aneurysm. This is the follow-up of the patient, and in the conclusion, we can say the endovascular treatment of fused renal abdominal aortic aneurysm from any alternative method in years can be method of choice. To use various technique and device reduce the dependence of endovascular treatment of the primary parameter for the landing zone, to use local anesthesia with light sedation, eliminate the need for the patient stay in the intensive care, the use of closing device always to patient move after the 2nd hour of the procedure, and this procedure, it's safety for the patient, and we can use in the group patient when it's need. Thank you.
Thank you, Professor Stankov. In fact, these are the majority, in fact, thoracoabdominal aneurysm, not just juxtarenal. So all these data are more than 2 chimneys. In fact, we have to mention that every use more than 2 chimneys is off-label. So in fact, even the first that we did was off-label. After that, it became on-label with 2 chimneys, but everything that is more than 2 chimneys is off-label. But it's doable. Professor Nikolov mentioned the possible endoleaks by the gutters. In fact, to avoid gutters, you to know, it's quite important to calculate the proper oversizing. So the definition and the rule for oversizing of the main body is to calculate half of the sum of all chimneys. So in case we have, for example, 3 chimneys of 6 millimeters, it means 18 millimeters, the half is 9. In case we calculate the main body to be 30 millimeters, we have to add 9 more, 39. The problem is that 39 graph doesn't exist. So yeah, so
there is a limitation.
Exactly, and because of that, everybody has to calculate all these things during the planning in order to avoid late complications, late interventional procedures, because the Professor Stankov will show you, but the secondary procedures regarding endoleaks, late migration, late complications, the correction of these late tasks is very difficult. So it's putting stents, plugs, stent grafts, coils, and speaking about reimbursement, in fact, the specific coils reimbursement in Bulgaria is very limited. and it can reach the sum of co-payment that is not affordable. And all these anatomical cases are very expensive. Dr. Criado mentioned already how much in US, in a rich country like US can reach. Some comments? Are you pro-chimney? Are you pro-fenestration?
Definitely pro-fenestration.
Okay.
And the main problem with chimneys is exactly what you mentioned. We cannot have proper oversizing in a big neck. So this is limitation. We cannot treat with chimneys, with 3 or 4 chimneys, more than 26, 28 aortic neck.
Absolutely.
Effect.
I'll show you tomorrow for the chimneys in the arch that we are routinely using chimneys since more than 5 years and fenestration since one year, but in situ fenestration, not
So,
physician
Never
modified.
mind, you prefer fenestrations now, right?
In
Or
fact, we have
exactly.
several cases in which we, by purpose, we have used chimneys and fenestration. So there is no dispute between chimneys and fenestration. In fact, everything, probably the most important is to emphasize that we have plethora of possibilities, and a typical aortic center, the best way is to have different ways of intervention, because in some patients definitely we need a combination of different endovascular approaches in one and the same patient, or even in some cases combining hybrid, surgical, and so on. We are not against surgical. Of course, we are definitely working together in an excellent way.
And many times the final decision depends on the limitations.
Absolutely. Okay, any questions, comments from the audience? Okay. You saw it's so simple, so joking. Frank, do you want to say?
Do you think yourself you're going to be doing more fenestrated moving forward than you did in the past?
It's probably better idea to make fenestrations and our combination. So I think it's time for lunch, and thank you for your attention. Lunch in 1 hour time, coming back together.